Thank you, Rajalakshmi, and good afternoon, everybody. So today we are having an important topic, uh, respiratory symptoms, and mainly we are going to talk about breathlessness and cough. Breathlessness is a very common symptom that can occur not only in patients who have respiratory diseases, but also in any other patients uh, with any other diseases, especially with cardiac diseases and so many other diseases. So, if you have experienced breathlessness once in your life, you will understand the impact of breathlessness on patients, caregivers, and caregivers. Sometimes, what happens, the patient will feel that they are going to die. And we also know that patients with chronic respiratory problems like COPD, interstitial lung disease, they all have respiratory problems in addition to patients with malignancy of the lung. It is a very difficult to control symptoms because there are multiple factors involved in it. So today the session will be handled by Dr. Rajam Iyer. And Dr. Rajam is a pulmonologist who is working at Mumbai. She is trying to integrate the principles of palliative care into pulmonology, and she is also um, stimulating other pulmonologists regarding the contribution of palliative care in pulmonology. So uh, she has been also working with palliative care for some years. Uh, so you will enjoy this class, and it's over to you, Dr. Rajam.
Thank you, Sunil and Rajalakshmi. And like I always say, before this time of the day in India, post lunch can be quite drab to listen to somebody non-stop for 40 minutes. So I would request you all to have an interactive session. Sunil, my colleague from Kerala, will keep an eye on the chat. Please feel free to interrupt and interject at any time so that it becomes more interesting and I learn from you and I hope you also learn from me. So with that and with your permission, Sunil, I will share the screen for today's presentation. And like Sunil mentioned to you, today we are going to talk about respiratory symptoms and the palliative approach to in respiratory diseases. I think the time has come in the country to actually integrate palliative care with all specialities. And I think we would have handled the pandemic much better if we had more doctors trained in palliative care, more doctors who are fully aware of the psychosocial, of the palliative care approaches to symptoms, of how to triage and select patients. I think the whole the brunt that we bore and probably continue to bear with the pandemic, sorry, could have been a little bit lesser if we had more doctors like you interested and trained in palliative care. So with that, today's topic we will divide into four main categories. One is to actually convince with all of you the need for palliative care in respiratory medicine. Then to share with you the definition of chronic breathlessness syndrome and how to manage it, a little bit about morphine and other respiratory symptoms. So to start with the need, I'm sure you've had other topics in other organ involvement about why every system and every speciality needs to be integrated with palliative care. To start with, we basically need to realize that uh, what is important, the principle and ethos of palliative care for everything is because if you sit back and think of any of the organs, which are the conditions that we actually manage to fully cure in gastro, be it cardio, be it neurology, be it renal and respiratory. If you can send some responses in the chat box, which are the conditions that we are able to fully cure when in a particular this thing. And if you think of respiratory symptoms also, if you see most of the conditions which we fully cure are the infections. So the pneumonias, especially bacterial pneumonia, tuberculosis, drug sensitive tuberculosis, we are able to fully cure. By and large, you can actually say that we are able to cure one third of the diseases, we are able to control one third, and we are not able to do anything that is incurable is one third. Therefore, most of the organs involved, any organ, we will be able to probably cure only one third. And therefore, the need for palliative care is so much more in the groups which are only controllable and in the groups which is incurable. So, coming to this, just to emphasize on the amount of Indians affected by non communicable diseases, this source is, of course, a 2007. I think I need to update this slide, but we need to realize that the number of people who are affected by lifestyle conditions like COPD, asthma, diabetes, heart disease, stroke, and respiratory diseases almost forms 45 to 50% of Indians. If you see, cancer comes down, and we do add 1 million cancer patients every year to our population. But if you see the amount of Indians affected by lifestyle diseases like heart, stroke, lung diseases, diabetes, etc., it forms a large chunk of people. And therefore, we need to realize none of these conditions are completely curable. They're either controllable or after a particular time become incurable. So you realize that in India, though many often doctors as well as the community at large feel palliative care is meant for advanced cancer patients, it is very clear here that it's not just for cancer patients. It needs to be integrated with all specialties, therefore, respiratory specialty also. And if you actually see the numbers, they're quite staggering. We do have 18% of the world's population, depending on the surface area of India. But unfortunately, the burden of respiratory diseases is almost 32% of the world. So we have a lot of patients suffering from chronic respiratory diseases. We actually bear one third of the global burden. And we are also now slowly an aging population. So as our country becomes old, we're going to have more and more people above the age of 60 and 700% rise above the age of 80. So we are going to have a geriatric society in 30 years by the year of 2050, which means the reason I brought this up is it is shown by evidence in literature that above the age of 65, every individual suffers from one or at least two chronic illnesses, which means that the handholding that is required and the palliative care approach is going to only increase. And one of the main symptoms in respiratory system that we see is breathlessness. But like Sunil said, it is not just because of respiratory. Cardiac conditions, neuromuscular conditions, advanced cancers also contribute to the large number of breathlessness patient. And breathlessness can be a very important symptom or a very common symptom at the end of life. So just to review a nutshell of the causes of severe breathlessness, in the lung, you should think of airways, so advanced asthma, COPD, bronchiectasis, parenchymal, which is interstitial lung disease, which has got more than 2000 causes, vascular, like pulmonary hypertension and pulmonary embolism, and pleural effusions. Besides that, like I told you, neuromuscular conditions, advanced lung, which spread to the lung, as well as the fact that the patient is deconditioned, and this called as the anorexia cachexia syndrome. Any comments, Sunil, that you want to add upon? So there's a
No,
comment.
madam.
There's one comment by Dr. V.B. Carle saying,
Yeah.
why do you call respiratory diseases as lifestyle diseases? No, I meant lifestyle diseases as diabetes, hypertension, dyslipidemia, cardiac conditions. Yes, smoking and certain conditions which contribute to respiratory diseases can be considered lifestyle. But what I wanted to actually emphasize, Dr. Kale, here is that cancer is not the only indication for palliative care as traditionally started. Other specialties also need to, because all other specialties have equal number of conditions which are incurable or which can only be controlled. So therefore, as a concept of a non-communicable disease, non-communicable diseases are perceived as less life limiting. So if you diagnose a patient to have cancer, he already starts thinking of his death. While if you diagnose a patient to have COPD or interstitial lung disease, he doesn't start thinking of his death. He thinks whatever treatment he's getting is the treatment of the condition. We need to realize that we are treating only the symptoms because of the condition. We are not doing anything to alter the anatomy of the lung. Therefore, it is important to make it very clear. This was the slide to emphasize that yes, other conditions also require the attention of palliative care. So these were the causes which I'm sure all of you know. I also think if you've already attended 12 sessions of palliative care by now, you would have seen this graph, this particular depiction of how the trajectory of people who are dying. And please remember that the needs of people at the end of life are similar, irrespective of the diagnosis, whether it is cancer, dementia, CKD, diabetes, heart disease, respiratory disease, the needs are the same. And palliative care addresses these needs. Therefore, palliative care is essential for all people dying, irrespective of any cause. And in chronic illnesses, we really need to support them much earlier so that the journey is bearable. So, if you see this graph, if I quickly explain to you, there are under 10% of people who die sudden deaths. Although most of you, if you were asked how you would like to end, how you would like your death to be, most of us want it sudden, that we go to sleep and never wake up. But please remember that this is not going to happen to all of us. It's going to happen only amongst 7% of people. The rest of the people are going to go through a bed bound phase. And if you see graph B, this could be compared to a graph which is seen in cancer patients who enjoy a good quality of life for a fairly good period of time, depending on the etiology of the cancer, and then starts the sharp decline wherein they will need the palliative care support. Today, we are going to focus on graph 3. And what is graph 3? You can actually compare graph 3 to any organ failure. And that means that when the patient is diagnosed to have that particular illness, say for example, COPD, he is probably 60 or 65 years at the time of diagnosis. He then leads a 10 to 15 years of symptoms with COPD or life with COPD, which is frequently punctuated or fairly often punctuated with multiple acute admissions to the hospital. Each admission to the hospital could have been because of an acute event, could have resulted in death, but he survives, but his quality of life is slowly but steadily decreasing, and he becomes more and more dependent. And you also need to realize that the symptom burden increases along with the prolonged period of time. So you realize that a lot of our patients, almost 16% of patients, are in and out of hospitals, independent for activities of daily living, slowly getting housebound and bedbound, and leading a slow social death and a very frail quality of life till death. So, a lot of our respiratory patients fit into this. And the last trajectory is that which you can compare it to any elderly or ones who are frail or with dementia, who for a long period of time slowly wither away and become 90, 92, and then eventually pass away. So we realize that all these three graphs need palliative care, especially this organ failure, because we never realize what the patient and the family goes through when you have to look after one such patient at home. It is a 24/7 job with no respite and constant attention and monitoring. So either the patient is breathless, patient is not able to go to the toilet, patient is not able to walk, patient is not able to talk, patient not able to eat. So many things are happening to the patient at home, while we as pulmonologists see this patient only in an acute event in the hospital. So with this is an important graph to remember, and to improve this journey of the patient, we really need to integrate palliative care along with pulmonary medicine. Very, very important to experience a good care for our patients. So types of breathlessness, we usually can divide it according to the duration by acute, acute on chronic, and chronic. Obviously, acute first time breathlessness is something that we need to get to the bottom of it. We need to see to that we do everything for the patient. So it's not the purview of today's talk. Today's talk is those patients who are breathless day after day, week after week, month after month for years together. And these patients can develop an acute exacerbation either due to infection or weather change or any of this. And therefore, we will focus on acute and chronic breathlessness. You all already know about the scales used to assess breathlessness. The New York Heart Association uses class 1 to class 4, and the Modified Medical Research Council uses grade 0 to grade 4, where grade 0 or class 1 is where the patient is breathless only on very strenuous exercise, and grade 4 or class 4 is when patient is breathless even with minimal to no activity without leaving his house and on simple activities of daily living. So this is how we measure or analyze breathlessness. And moving further, whenever you have a patient of breathlessness, obviously a detailed history will always help. A clinical examination helps to find out which part of the system, the heart, the lung, the deconditioning, what is actually contributing to the breathlessness. And there are a certain must do investigations which are a part of this list, which should be an X-ray chest, ECG, a 2D echo. Please do remember that a pulmonary function test is very, very important to find out which part of the lung is affected, whether it's obstructive, whether it's restrictive, and what you could do to further investigate, which could be the CT scan or arterial blood gas. So I think it is important to emphasize that we need to do more and more dedicated lung function tests, computerized complete lung function test with bronchodilator reversibility, with diffusion capacity in appropriate settings, along with 6-minute walk test. So please remember that to include it in your evaluation of breathlessness, especially in those patients who are able to do so, not so advanced in their illness. When we are trained in MBBS and MD to look after patients, the way we ask history taking is so focused on the physical well being of the patient. And as all of you would have known by now, after attending so many sessions on palliative care, that health is not just a mere absence of illness. We need to look at the human being in total. Therefore, if you think of a person who is breathless, like Sunil introduced, if any of you have felt breathless or any of you are an asthmatic and you have been out of breath, you know exactly how our patients with advanced lung disease feel. So it's not just the physical symptoms that bothers, it is what the patient spirals into. It is anxiety, it is dependence, it is frustration, it is fear of death, it is panic. Suddenly, this man who actually ran the house has become just a patient on the bed and he's got complete loss of role. So there is a multiple things happening to our patients that is beautifully explained by this thinking, breathing, functioning model. Which, if you see that if our patient of, say, advanced COPD or interstitial lung is very breathless, his accessory muscles are working, his respiratory rate is high, his work of breathing is high, he's panting, automatically he's able to do less. And this sets off the only thing that is so hyperactive is his mind. He gets anxious, he's scared, he feels there is imminent death, and so he panics even more and he gets even more breathless. As a result of these two things, the thinking and the breathing, the patient now feels that I used to be able to walk 10 steps. Now, even if I walk 2 steps, I'm feeling breathless. So it's better I don't walk. So he gets into this deconditioning mode where if he doesn't use his muscles, he loses his muscles. So he gets more and more deconditioned. And our patients get caught in this vicious cycle of being having a problem with the lungs or the heart or an advanced cancer, therefore they're breathless. Then they start getting worried, panicking, and anxiety. Then they start moving even less and therefore becoming more and more deconditioned. So our patients are caught in this vicious cycle. This is the cycle that palliative care wants to break. So by being a multidisciplinary team, we not only have a doctor, but we have a nurse, we have a physiotherapist, we have counselors, we have social workers. So all these people, when they come into action, they can actually support the patient and their caregivers to see to it that this vicious cycle is broken with the help of a counselor and a physiotherapist and a respiratory therapist nurse who's constantly adjusting the medications of this patient. So that brings us to chronic breathlessness syndrome. So to just to explain to you how we ask questions to our patients, very often we ask the patient, is your breathlessness better or are you breathless? So we ask very closed ended questions for which the patient gets cornered to answer. In order to get more out of the patient, we really need to frame our questions differently. So we need to either ask him, are you coping with your breathlessness? Or what are the things you're not able to do because of being breathless? Or because of your breathlessness, what are the things you have stopped doing? So this can open the Pandora's box, and the patient can then tell you how the breathlessness has affected his daily life. And that is where palliative care interventions will really do magic. So, coming to this, I also find very often that doctors find it very difficult, especially in non communicable diseases, as to when to start palliative care. Too early, maybe, defeating the purpose of losing hope. too late is really not beneficial to the patient. So there is this very interesting question that has been researched in England, and this is for general practitioners who refer the patients to specialities to think of, will you be surprised if the patient is not alive in the next 12 months? You ask this question to yourself when this patient is sitting in front of you. And if the answer to this question is a no, it is time for proactive palliative care. So, to simplify this further, both Manipal Hospital as well as the gold standard framework have come with criteria in, say, COPD of when you should think of palliative care referral. And if the patient satisfies any of these two, which is recurrent hospital admissions, MRC grade 4 or 5, patient on continuous oxygen, requiring one ITU or admission or a non invasive ventilator, presence of comorbid factors like right heart failure, cachexia, diabetes, severe hypertension, severe pulmonary hypertension, if the patient has any PFT values which suggests a severe illness, if the patient has any of these two criteria, it is time to integrate palliative care along with your respiratory treatment, pulmonary rehab, counseling, all of that. So it makes it simple for us to therefore not lose patients at this stage of their illness before they become worse. We can intervene to not change the trajectory because we cannot change the anatomy, but at least we can make the journey more bearable for both the patients and the caregivers. So, what we actually do is in our mind ask the surprise question. If you feel the answer is no, you directly send them to the palliative care program. If it is somewhere in the middle or if it is deaf, so then there is a clear cut thing of how you follow up these patients. So you follow up these patients more closely and then you at an appropriate time refer them to palliative care. So, coming back to the definition of chronic breathlessness syndrome. So, by definition, chronic breathlessness is defined as a condition in which the patient who is on optimum treatment for his underlying medical condition, but the breathlessness contributes to physical limitations and adversely affects his psychosocial, spiritual, and other activities of daily living. It's not necessary that patient needs to be chronic breathless for a particular time. Any breathlessness which is contributing to a change, is not coping the patient or the family members, is chronic breathlessness syndrome. So all cases of advanced lung diseases, congestive cardiac failure in an advanced stage or an elderly patient, motor neuron disease where the muscles of respiration don't work, advanced cancers, all can fit into chronic breathlessness syndrome. So, when you have a patient of chronic breathlessness syndrome, there is something that we can do for all patients. And what is that? We can first explore the values, fears, and belief of the patient and offer psychosocial support. We can teach him relaxation techniques by the physiotherapist. There are things like we can make the patient sit next to a window, wear loose clothes, fan blowing, a battery operated fan blowing in the face of the patient can really settle that patient and decrease his sensation of breathlessness. By giving the patient certain position, also it helps to relieve the breathlessness. And of course, by having patient support groups and looking after the patient and supporting him during this time. So there are a lot of non-pharmacological interventions that caregivers can be taught, maybe massage, acupuncture, loose clothes, positioning, fan blowing, some distraction like music therapy, pet therapy. All these things can actually address to decrease the breathlessness. And then coming to pharmacological, of course, we are all aware that we need to treat according to the underlying etiology. So, depending on what the underlying etiology, you can give bronchodilators, steroids, and the inhalers can be given even through nebulizer. Plus, you also need to remember that you can add antibiotics if there is an infection, which is documented by a high count as well as fever, as well as X-ray, which is abnormal. Antifibrotics, which is very useful in progressive fibrosing interstitial lung disease. I would like to draw your attention to oxygen. All breathless patients need not get oxygen. You need to give oxygen only in patients who are hypoxemic, which means the saturation levels are below 88. Remember, oxygen is also a pharmacological drug. Excess of oxygen also causes damage by nascent free oxygen. In the COVID pandemic, we have seen how high flow nasal oxygen ends up in giving fungal infections because of the steroids, obviously the overall picture of steroids, diabetes, as well as the moist nasal flow that is going. So please remember, all our patients with advanced lung diseases should maintain oxygen between 88 and 92. Oxygen should be prescribed only when the oxygen levels are below 88. Okay. So coming to the very important part of treating breathlessness. So this is something that most of the pulmonologists whom I talk to fall off their chair. They say, how can you give morphine in breathless patients? So please remember that the morphine we use in breathless patients is not the same dose as that of pain. It is a narcotic, it is a strong analgesic, and it is reserved for very severe pain. But in low doses, very, very small doses, it acts very well in removing the sensation of breathlessness. So, morphine decreases the work of breathing, it improves the tidal respiration, it decreases the accessory muscles use, and what it does is decreases the respiratory rate. So the patient feels less breathless. It doesn't do anything to the airway, it doesn't do anything to the interstitium. So the whole purpose of giving morphine is to improve the quality of life, because we know that the underlying pathophysiology is incurable. So the doses of morphine we use is very, very small. We usually start with oral 2.5 milligrams twice a day and titrate it by 25% weekly. If we have to give orally, I mean injectable, we decrease the dose of morphine, and we can keep seeing to it that we review the patient every 1 week if the patient is at home. Please remember, the half life of morphine is only 4 hours. So initially we start with the 12-hour gap and slowly increase it. But we never need to give more than 30 milligrams for chronic breathlessness. So please remember, you need to have a proper assessment and a proper history of the patient and diagnose him to be chronic breathless before you start the morphine. And if you feel the patient has anxiety, you can add a medium acting benzodiazepine or a longer acting benzodiazepine like midazolam if the patient is panicking. So please remember, underlying treatment like oxygen, like bronchodilators, steroids are all going on simultaneously. Despite that, when the patient is breathless, you can add a small dose of morphine. And this is what we have also been doing during the COVID-19 pandemic. Patient is already on oxygen, prone position, getting his steroids, getting his antibiotics, getting remdesivir, and the patient continues to have symptoms of breathlessness and to allay anxiety, because anxiety is at very high, especially in all patients are isolated and alone. We start the patient on low dose morphine and help him tide over the crisis of breathlessness. Okay, so very often there's a lot of phobia associated with morphine, that I don't have cancer, I don't have pain, I'm not ready to die. Morphine is given only for people who are ready to die, it's only for cancer patients. So none of this is true. Please remember, there is enough studies to suggest that it's a very safe drug. In low doses, highly effective. Always start low, go slow. Doesn't cause respiratory depression and doesn't cause worsening of carbon dioxide. Any comments or suggestions, or shall I go on? So there's a question of midazolam, how much?
Yeah.
Again, midazolam, we give it on SOS basis. So if the patient is in hospital, we can give subcut 1 to 2 milligrams on need basis if the patient is having anxiety. Otherwise, if the patient is at home, we can give the patient either subcut or nocturnal midazolam so that the patient has a comfortable night's rest. Then coming to something that most patients of ours experience during the end of life, which is terminal breathlessness. Terminal breathlessness can be experienced by lot of patients, even if they're not respiratory patients, at the end of life. And especially for the family and the patient, it can be very, very uncomfortable sight. As all of you know, the famous quote of Dame Cicely Saunders, the manner in which a loved one passes away is etched in those who live on. So it has to be a comfortable transition for the patients. And therefore, it's very sad to think that today India has amongst the 15 worst countries to die in, and we have a very poor quality of death index. And we really need to change this with the help of all of you trained in palliative care to give our dying patients dignity and respect they deserve, and also a comfortable, suffering free end. So for terminal breathlessness, the medications we use is a 24-hour infusion, usually subcutaneous under the skin, through a syringe pump or a scalp vein, which has a combination of 10 milligrams of morphine and 10 milligrams of midazolam given slowly. Please remember that when you treat terminal breathlessness, the intent is comfort of the patient. You have to have good communication with all the people, including the patient, because patient may get more and more unresponsive after starting the infusion. So you cannot be, relatives should not be saying that you gave this injection and my patient died. So the communication has to be perfect, the documentation has to be perfect, and the rationale of starting this subcute infusion is to aggressively control symptoms of the patient, and intent is to comfort the patient. Usually, we don't need to give it more than 2 to 3 days, even that is a lot. But the careful selection of patients where you need to give of terminal breathlessness, when you diagnose active dying and you know whatever you're doing, you're increasing the oxygen, you're giving nebulizers, you're giving steroids, but the oxygen is just not picking up and the patient is absolutely like a fish out of water. And that's the time you initiate terminal breathlessness. Please remember, communication, documentation, extremely important. In some parts of the world, this treatment of terminal breathlessness is also called as palliative sedation. Some palliative care experts have a problem in using this terminology because it almost seems that you're hastening death. But please remember that is not the intent of treating terminal breathlessness. The intent is comfort. We are no one to induce death, hasten it, or postpone it, because we are only doctors with an empathetic heart. So, just to reiterate the fact of when to use midazolam, it is usually for breathlessness with anxiety. Like somebody had asked the doses, it is clear that 2.5 to 5 milligrams subcutaneous can be given SOS basis in emergencies. And from that time, you can see in the slide how you can give it for various, you do give it before endoscopy, you give it before bronchoscopy. So you please remember that for terminal symptoms, you can give up to 5 milligrams subcutaneous every 24 hours. And in the infusion, when it becomes worse, you can also add 10 milligrams along with morphine. So it helps in decreasing the anxiety of the patients. So this was with chronic breathlessness, use of morphine, how to use morphine, how to combine it, and how to use for terminal breathlessness. I am just looking at the time. Uh, it is about 3:30. So within the next 7 or 8 minutes, I'm going to go through other respiratory symptoms, and then we can stop to discuss. So one of the symptoms which we need to talk about is secretions. Very often we see patients being subjected to suction, whether it's a stroke patient, whether it's a pneumonia patient, or a patient with bronchiectasis with copious secretions. Please remember that the palliative care approach is addressed towards comfort of the patient. So for such situations, we need to see how we can decrease the secretions and therefore make the patient more comfortable. But please do remember that decreasing secretions doesn't making the patient over dry. So you can use it in patients who are drooling, in patients with MND, with saliva accumulated in the mouth, progressive supranuclear palsy. All these conditions, you can use either of these medications, hyoscine or glycopyrrolate. Glycopyrrolate is preferred in terminal secretions, or I mean, both can be used in terminal secretions, but you have to watch for glaucoma in hyoscine and glycopyrrolate. Please remember the doses are, 2 to 4 in hyoscine, and glycopyrrolate is 0.2 to zero point 0.4. I would best start using this as need basis before you make it a regular dose of medications to decrease the secretions, because secretions can be extremely distressing for the patient and it's almost like a choking sensation. And in some cases, just before death, the death rattle that we talk about can also be treated by these medications to decrease secretions. As you all know, cough, which is the next second most important symptom in respiratory medicine, it's a protective reflex, no doubt about it. But when it becomes persistent, it can become quite irritable and it can be very disruptive for the patient's life. It can affect sleep, eating. It can cause rib fractures, hernia, syncope. So please do remember, again, causes could be everything, not just the chest. Gastro, cardiac, drugs, treatment like fibrosis, and sometimes even psychogenic and drugs. So do remember that you can classify the cough as dry cough, wet cough, something which is due to centrally due to the cough center, as well as peripherally. So you can do local treatments also, and you can suppress the cough from the center also. So there are many medications available for distressing cough, but I would always try to start with simpler ones, like first get to the etiology after a detailed history and clinical examination. Then you can start, if there's an infection, rule out the infection, correct the correctables, treat the underlying lung physiology optimally with bronchodilators, antibiotics, antifibrotics, etc. Then you could use things like start with simple hot water, home remedies like honey, ginger, lozenges. Next step would be Tossex, which is codeine, which is a weak opioid. And subsequent to that, if you feel the cough is because of a psychogenic reason, you can add SSRIs like citalopram. But there are two medications which has worked well with cough. One is gabapentin, which is a fairly recent discovery, which is an anti-epileptic but can be used for treatment of cough, and also morphine. Like how breathlessness can be controlled, even cough can be controlled, especially if those which are persistent, irritable, and intractable cough. So do remember gabapentin as well as morphine for the treatment of cough. Next, we come to pleural effusion, again commonly seen in a cancer setting patient. It could be a transudate or an exudate. A lot of the local conditions like breast, lung, bone, these do cause effusion to the ovaries. They cause an effusion into the lung. Please do remember that when we have patients with a massive pleural effusion, it can cause a mediastinal shift and a ventilation perfusion mismatch, and these patients can be breathless. And just to let you know that the way we manage pleural effusion is by not just the size, but also the prognosis of the patient. So if it's a metastatic pleural effusion due to a cancer and the patient is not expected to live more than 4 weeks, we then do immediate relief by putting a aspiration and removing it. But if the patient is supposed to or known to have a good prognosis, then we put in a long indwelling pigtail catheter, and this patient slowly let the fluid drain out, so that it's not repeated admissions and it's not repeated visits to the hospital. Then once you're able to actually dry this patient of the fluid, we can do procedures like pleurodesis, where we inject an inflammable substance or even an a chemotherapeutic agent like bleomycin, and cause intense inflammation between the visceral and the parietal pleura, and they then tend to stick to each other, obviating the potential space and therefore hoping that there will be no fluid collection. Okay. So please remember, it depends on the severity, the performance status, and the response to systemic therapy. And that's how we treat pleural effusion. Hemoptysis is another very important symptom. It can be very scary for the patient, and a lot of patients don't die of blood loss, they die of aspiration of blood into their own system. So again, with hemoptysis, you need a bit more specialized palliative approaches in hospital, like brachytherapy, cryotherapy, laser. You can do a bronchoscopy and do laser treatment and actually burn out the tumor if it's that is the reason for the bleeding. And therefore there are a little more uh, uh, what do you say, specialized interventions for dealing with hemoptysis. And the last thing I would like to come is hiccups, which could be mainly due to gastrointestinal, but it is obviously the diaphragmatic contraction, and therefore the again this basic investigations is CT. If it's intractable, you should do these things, but otherwise the management includes sudden distraction, or you could dilute the acid by just water or PPIs, prokinetics, and the higher treatment for hiccups is with dopamine antagonists, as well as other treatments which we use, which is centrally acting, which is like haloperidol and midazolam. So other non-pharmacological stimulation like nasal stimulation, or like I said, some respiratory maneuvers also help. So with that, I will end my presentation, but I'm happy to take questions and discuss the case also. Sunil, anything in the chat that you would like me to take? Sunil, over to you.
Dr. Sunil, you are muted. Yes, sir.
Sorry, my earphone is not working, so I am searching for another earphone.
Anybody would like to ask a question? or clarification?
Ma'am, hello.
Shilpa?
Yes, ma'am. Um, I just wanted to ask,
Sorry, go on.
ma'am, I just wanted to ask, please, could you elaborate role of gabapentin for treatment of persistent cough, the
Yeah, so
dosage, and
it's
I
a
couldn't get
recent,
that.
no, no, it's a recent discovery. As you all know, it's an anti-epileptic and a fairly expensive one at that. But because one of the side effects is also drowsiness, we usually try gabapentin at 100 milligrams at night and increase it to 300 or 600 milligrams a day. And it is found to be useful in intractable cough, sorry, after you have used all the other things, for example, optimum treatment for your underlying lung conditions, topical treatment like lozenges, gargling, treatment of GERD, you have used all that and still the patient is intractable cough, you can try Tossex. The next level could be gabapentin before you think of morphine. So there are papers published now that for refractory cough they have found gabapentin to be useful. Am I clear, Shilpa?
Yes, ma'am. Yes, ma'am. Thank you. Ma'am, could you please share those papers if
I will send
possible?
it to Rajalakshmi, definitely.
Thank you. Thank you, ma'am.
Hello, ma'am.
Yes.
Dr. Deepthi here from Kerala. I'm also
Hi.
a pulmonologist, ma'am. So glad to hear from a pulmonologist. Ma'am, we have many COPD patients, interstitial lung disease patients with ILDs who have end-stage lung disease, who have severe breathlessness in spite of all optimized medications. Patients continue to have breathlessness. Ma'am, your class was extremely useful for someone like me. And also, another thing that we are facing right now is patients suffering from COVID. Patients who present with COVID severe disease category C who are on non-invasive ventilation who continue to have breathlessness, patients who have recovered from COVID-19 infection who are suffering from post-COVID lung damages, who we find it very difficult to wean off ventilators and non-invasive ventilation and all such things. So, madam, for patients who are on non-invasive ventilations who continue to have breathlessness, can we prescribe opioid drugs for those patients? What is
Yes,
your opinion, ma'am?
100%. 100%. So, the way I have started practice in palliative care only since the past 5 years, I have just finished my training from Cardiff. And what we do, I work closely with other senior pulmonologists. So, all those patients who are on optimum treatment for their underlying condition and continue to be breathless, or when their life is affected by breathlessness, like you mentioned, we have started using patients, we have started giving patients low dose morphine, 2.5 milligrams we give 12 hourly along with laxatives, slowly increase it to 3 times and 4 times a day, and keep in touch with the patient and review the patient. So I'm very glad to share that patients do so well. For example, for that particular patient, the fact that he can go to the toilet alone or walk to the dining table and eat with his family, it means a lot. We really make a difference in the quality of life of patients. And coming to COVID-19, just today, I had one of my patients who was in the hospital for 4 weeks. I think two of which 2 weeks on the ventilator and 2 weeks on NIV. Finally, couldn't he was desaturating and so breathless just by turning in the bed. We started physio with oxygen and morphine, and today he's off oxygen. Today he is able to climb one flight of stairs, and we have started tapering off the morphine. So please remember, use morphine judiciously in small effective doses after properly evaluating whether all other treatments for breathlessness has been enoughly given. Once you have established that, then low dose morphine slowly and steadily. You start with 2.5 12 hourly and you encourage the patient. It really does make a difference. You will make a huge difference in the quality of life of your patients. And Deepthi, I would like to also tell you that because I'm a part of the Indian Chest Society and the Association of Palliative Care, we have actually brought out modules for pulmonologists in palliative care, and we finished 3 modules. 3 more will come once the pandemic settles down. So if you're interested, please look at the website of both IAPC as well as Indian Chest Society, because we are aiming to really get pulmonologists think of palliative care. Because like I said before, if all the pulmonologists and the internists as well as the intensivists knew about palliative care, we would have handled this pandemic way better than what we did. So there is a lot to be learned from this. morphine is very safe, and I use it regularly in post-COVID.
Thank you, ma'am. Thank you so much.
There is a question in the chat of how to distinguish breathlessness in cardiac as well as
So I think
respiratory origin.
the history is the first, age group will be first, history will be first. For example, the history in a respiratory breathlessness will be cough, may or may not be chest pain, progressive breathlessness. In asthma, it will be intermittent episodic breathlessness. There'll be cough. While in a cardiac, typically the age group might, it's not true that 40-year-olds can't have heart disease, but typically it will be elderly age group, chest pain. It is also something that the pain is probably the first thing that comes, and then the patient can be breathless. There's edema, feet, cough might not be such a big thing. So I think history taking is first, and of course evaluation. So if you hear rhonchi, it's likely to be due to the chest, but if you hear abnormal heart sounds, pedal edema, raised JVP, those things can point out towards cardiac. And then of course investigations like echo, HRCT, pulmonary function test, all this will help you. But history taking, I guess, is very, very important. No, Deepti, it's not a sustained release. In Bombay, we get only immediate release, and we get 10 milligram tablets. We break the tablet into 4 and give 1/4 to the patient. But I'm not sure whether Kerala has sustained release. Does Kerala have sustained release?
No. Sustained release morphine is not available.
Yeah, but if you see the foreign papers, morphine in respiratory in chronic breathlessness syndrome, they all talk of 10 milligram sustained release twice a day. But we start on a low dose because it is also something that is advised by papers. So I can share those papers also with Rajalakshmi. I'm sure Sunil also has plenty that he can share with you. Any more questions?
Yeah.
Hyoscine and
rolling in kids.
in kids, I really don't know. Sunil, can you help me? I'm never treated children.
I think we can use the same hyacinth butyl bromide or glycopyrrolate, but I don't know the weight by the
Milligram per
dosage.
kilogram.
Yeah, dosage of children, but I can send it to you with the learning material. Yeah.
So Rajalakshmi, can you note down the things we have to send? Is one is secretion, anti-secretory doses for children, morphine in chronic breathlessness, and gabapentin in cough. If you can send me an email, I can attach the references.
So just to also make a few comments regarding morphine and treatment of breathlessness. So a 2020 or 21 article on breathlessness, it says with the 10 milligram of morphine, 70% of the patients who are breathless will respond. So, usually the maximum dose required is 30 milligram. So the range is 10 to 30 milligram. And it is not like treating pain where we need higher doses. So remember, the dose of morphine for treating the breathlessness is much less than that is required for pain relief.
Thank you, Sunil. If there are no more questions, maybe we can go for the case. Is that okay? Or there are any questions?
Any questions? Any more questions?
Hello.
Yes, sir.
Dr. Kali from Nagpur. Madam, can you elaborate more on the death rattle glycopyrrolate dosing?
So it's the same, sir. Death rattle is secretions which is present.
How much?
Typically seen at end of life. It's 0.2 to 0.4. Correct, Sunil? SOS you can give. 0.2 to 0.4 can be given. Yeah, Sunil.
IM or subcut?
Subcu or IV. We usually don't give IM injections in palliative care.
In palliative care, we avoid. It's very painful. So we give, if there's a line.
IV.
Yes. If there is an IV, don't put an IV for it, then we give subcut. Or if there's a PEG tube or a Riles tube, we can give it through that.
Thank you.
And actually the injection glycopyrrolate can be given orally also.
Correct.
But not in terminal patients because they will aspirate. But in kids,
Oh,
if they have drooling of saliva, we can give
oh, subcu.
oral and no oral glycopyrrolate. The same injection can be given orally, and even atropine eye drop will be helpful.
Atropine, yes, right. Thank you. Thank you, Sunil.
Ma'am,
Yeah.
hello, ma'am.
Yes.
Yes.
Just I wanted to know that if you give this, when the patient has this breathlessness and rattling and like the towards the end, how much time can we give? Like suppose we treat.
So,
I mean, suppose the patient's relatives are coming and asking, ki, oh, that he's almost at that bed, and she's having that rattling breathlessness. And then how much means they ask, ki, how much time do you have? Kitna time? So how do we tell them? Like,
are you talking of prognostication of time of death?
Yes.
So the best way to deal with that, since you and me are not God, is to tell in days, hours to days, days to weeks, weeks to months. So if you have a patient who you know is actively dying, you can say it's a matter of few hours, maximum a day. Or you say days to weeks. It actually gives you a frame period to be comfortable. So you have not said 24 hours, 48 hours, like some of the doctors are used to saying it. Because, honestly speaking, I have been told off by patients by saying, you never told me he'll die in 2 days. Or, madam, you told me 2 months, he died in 1 week. So it's a very difficult thing. So best is to give a frame. If the patient is actively dying and you have all signs of that, you can say it's a matter of few hours to a day, or days to weeks, or weeks to months. That's the best way to prognosticate and safest way. And it's true because you really don't know. Some patients do surprise you. They kind of linger and linger and linger, and then they die. So very often the relatives are also, it's distressing for the relatives. But the idea that you have to then say is that we will try and keep the patient comfortable. Our duty is to see to it that even if we are not able to cure, we can care and comfort both you and the patient. We are not God to decide when to take off, right? You need to realize that we are really not God. It will happen when it has to happen. But we need to keep the patient comfortable for however long that journey is.
Thank you, ma'am.
Ma'am,
Thank
one
you.
more question, ma'am.
Yeah.
Ma'am, in COVID, we are dealing with COVID patients, and as another doctor said, that they suffer from extreme breathlessness even when they are on NIV and
Yes.
difficult to wean. So we don't have morphine, either injectable or oral here. We
Right.
don't have even fentanyl. We have butorphanol, or
Buprenorphine.
even.
Yeah.
So will it work, ma'am, and what
It should
dosage,
work.
please?
It should work. But where do you work, Shilpa?
Ma'am, we are working for COVID patients in the ICU in Medical College Ambikapur. This is in northern Chhattisgarh.
Understood. So, therefore, you need to contact Pallium India to see how you can register yourself as an RMI and get licensed to
Yes,
morphine.
ma'am.
It is not
Ma'am,
difficult.
yes, ma'am. I've sent out the application, ma'am, but
Yes,
it will take some time.
I agree. But buprenorphine, you have any experience, Sunil? With so we do use patches also for chronic breathlessness, but it takes time. It takes 12 hours. You don't even have fentanyl
No, ma'am. They don't even have fentanyl. And
in the
even in the
ICU.
OTs, even in the OT, they don't have.
I
So
think
you have buprenorphine, is it?
Yes,
he talked about butorphanol, isn't it? You told,
butorphanol, right?
yeah, both are different. Buprenorphine and butorphanol are different, but both are partial agonists. So most of the evidence for treatment of breathlessness is on morphine, and I have also seen few patients treated with the fentanyl, but I haven't seen any other opioids for treatment of breathlessness. But you have to actually try and see whether that patient responds to butorphanol.
But maybe we should do a hunt for them, because post-COVID breathlessness can be really difficult to handle. So maybe we should also look, but I think I would seriously suggest you all to get morphine, which is such a cheap and such an effective, wonderful drug, which improves the quality of life of our patients. So we will also look up at these two drugs. It will be a homework for us and get
Thank
back
you,
to
ma'am.
you.
Yes, sir. Yes, sir.
But Shilpa, have you attended the Pali COVID training?
Yes, ma'am.
You
I
have.
did. Yes.
Okay, anybody else? Okay, uh, so remember the conditions which can lead to breathlessness, including respiratory, cardiac, neuromuscular problems, and malignancy of the lung. So these are the common causes which can cause breathlessness. And it is, I think, another important thing is all those who are breathless may not have an fall of oxygen saturation. And it's also the other way is also right. So even if you put oxygen in a terminal patient, then actually we have to ask the patient whether it is giving any relief for breathlessness with oxygen. It is known as oxygen trial. You put oxygen for 10 minutes and assess the patient's comfort or relief of breathlessness. And if only patient is having relief, then you continue. Otherwise, you should not continue because there is a custom that oxygen is put for every patient who is dying. And you might have seen actually patients are pulling out the oxygen mask and throwing it away because it causes more breathlessness in some patients, and it is also a communication barrier. So that's also another important thing which you have to keep in mind. And madam talked about chronic breathlessness syndrome, and we might see many patients who are despite on maximal optimized therapy for breathlessness still have breathlessness. So in such patients, you can try low dose morphine. And non-pharmacological management are something which you need to be aware of. Like there are some evidence for a handheld stand and directed to the face can relieve breathlessness. So that's also important. So I think we can move on to the patient story. So which will be presented by Dr. Vaibhav.
Hello.
Yes, Dr.
Yes,
Vaibhav.
we can hear you.
Good afternoon, everyone. I'm Dr. Vaibhav Kohli. I'm working under Government of Uttarakhand as medical officer in Government Mela Hospital, Haridwar. Today, I'm presenting a case. It is of my wife's grandmother. Actually, unfortunately, she got expired one day before our marriage. Her age was 76 years with diagnosis of LVA with EF of 20% with dilated cardiomyopathy, bronchial asthma with recurrent UTI and gallbladder calculi. Next slide, please. He used to complain of dry cough on season change since 5 years, difficulty in breathing on exertion since 4 years, swelling present in both feet since 4 years, which usually subsides on medication. Increased frequency of maturation due to the diuretics she used to take since 4 years. Burning maturation since 1 year, decreased sleep since 1 year, pain abdomen, which was on and off since 2 years. She also used to complain of nausea since 6 months. Next slide. History of illness. A 76-year-old female reported with complaints of difficulty in breathing on exertion, swelling present in both feet, and increased frequency of maturation due to medication since 2017. The patient was diagnosed with LVF with EF of 20% and with dilated cardiomyopathy, bronchial asthma, and medication was started for the same. She would constantly complain of increased visits to the washroom because of the diuretics, which would also decrease her energy levels, due to which her compliance towards taking the medication would get affected. Hence, she had to be motivated regularly in order to take her medication as per schedule. She also reported with complaints of pain in abdomen, burning maturation, which was due to recurrent UTI, which usually subsided on taking medication, and decreased sleep also since past 1 year. Since the past 6 months, she also complained of regular episodes of nausea and vomiting, which usually subsided on taking medication. As per the family, patient was asymptomatic and was on regular medication. The patient slept following her usual schedule but did not wake up in the morning. She was declared dead by the visiting doctor, which happened 4 months back. Examination. General examination, blood pressure was 140 by 90 mm Hg, pulse rate 120 beats per minute, respiratory rate of 32 per minute, SpO2 ranging between 88 to 90 on room air, temperature 98.4 Fahrenheit, parallel icterus and cyanosis were absent. She was having bilateral pedal edema, pitting in nature. Systemic examination, CVS, cardiac, tachycardia, S1, S2 present, and there was no murmur. Respiratory, air entry bilaterally decreased, which was minimal. CNS, conscious oriented to time, place, and person. No sensory or motor deficit. Significant investigations, CBC with HP of 11.9, TLC counts of 12,500, ESR of 49, TCV 35, platelet count of 1.4, and RBC of 3.69. LFT with total bilirubin of 1.5, direct bilirubin of 0.8, SGOD of 120, and SGPT of 90. KFT showed urea of 40, creatinine 1, serum sodium of 137, and potassium 5.1. ECG showed signs of left bundle branch block. 2D echo done showed dilated cardiomyopathy, possibly ischemic, with severe LV systolic dysfunction, severe mitral regurgitation, mild aortic regurgitation, mild pulmonary arterial hypertension, severe tricuspid regurgitation, and with EF of 20%. Chest X-ray done showed left CP angle blunted, which was suggestive of pleural thickening and effusion. Cardiomegaly, both lung fields show prominent bronchovascular markings. Both the high level are prominent. USG abdomen done showed multiple calculi of 7 to 9 mm within the lumen of the gallbladder. Urine routine done showed pustules of 15 to 20 with presence of bacteria. Next slide, please. Medications given were tablet Cardase of 10 mg in the evening, tablet Concor 7.5 in the morning, tablet Ecosprin AV 75 by 10 in the evening, tablet Tide 20 mg in the morning and afternoon, syrup Ascoril LS 1 spoon twice a day, tablet Derifilin R150 twice a day, tablet Ciplox 500 mg twice a day, which was given every time during the reoccurrence of UTI, Symbicort W Haler 320 by 9 twice a day or on onset of sign of symptoms, tablet Pantocid 40 mg twice a day, empty stomach, tablet MCET on onset of sign of symptoms. But she was totally very non-compliant to these drugs, especially the tablet Tide, because it increased her visits to the washroom. She was also advised for laparoscopic cholecystectomy by the general surgeon, but she did not get cardiac clearance for the same. Next slide, please. Psychosocial aspects. The 76-year-old patient belonged to an upper middle class family background with 3 family members. She lost her young son a few years back in a road accident. She was upset about the loss but didn't get really share it with the family members. She would instead spend her time praying. The patient was depressed with the current situation of not being able to continue with her daily course as she used to do previously. She was distressed with the repeated exacerbation of the symptoms and repeated visits to the hospital. Patient also had fear of needles and admission to the hospital. Next slide, please. Summary: 76-year-old female with diagnosis of LVF with EF 20%, dilated cardiomyopathy, bronchial asthma, recurrent UTI, and gallbladder calculi. Patient was breathless on exertion, even to follow her usual routine activities. Poor compliance to the medication, as she would complain of weakness after taking diuretics. Next, discussion points. Any other medication that could have been added to the treatment which could have helped her in the symptomatic relief? Could palliative care help the patient? What step could have been taken to improve her compliance? And possible cause of death in sleep? Thank you so much, everyone.
Thank you, Dr. Vaibhav.
Yeah, thank you. Anybody wants to answer these questions after the talk? The questions are very much there. So somebody had asked about difference in cardiac breathlessness and respiratory breathlessness. It's very evident from the history what it was in here. Pedal edema, breathlessness on exertion, because of the cardiac status. So, Dr. Kohli, you yourself can tell me, so if you think palliative care could have helped, who all you think could have helped with this patient?
Ma'am, actually, I seriously can't tell about this. Ma'am, I don't know that if.
So you had said she lost her younger son. That's a horrible thing to happen to anybody. Losing
Yes,
a child is a really bad thing. And I think first thing that we probably could have helped her is with a counselor to get her grief sorted. Because when you are so
ma'am,
grieved, yeah.
ma'am, actually, her mother was a counselor only. She used to counsel her
Yeah,
on
but I
daily
don't,
basis.
it has to be
But
a professional counselor, Dr. Kohli, because when you get counseled by people you know, there's a lot of bias and there's a lot of judgment.
yes, ma'am.
It's best to do with this person you don't know at all. Because this, I told you so, ye karna chahiye tha, that is something that inadvertently comes out. So I
Yes,
think
ma'am.
professional counseling would have helped the elderly lady. And I definitely think, Sunil, correct me if I'm wrong, palliative care would have really supported the family a lot from preventing the multiple hospital admissions, from doing what the patient wants to do. See, one of the most important pillars of medical ethics is autonomy. Tomorrow, I am going to be in this patient's position. Imagine being taken to the hospital and given medications I don't want to take. So, jabardasti to take a person against the will is also torture, is also against normal medical treatment. So, palliative care involvement in this patient would have taken care of a grief, would have
Yes, ma'am.
prevented her repeated hospital admissions, would have also, by adding low dose morphine, I think somebody has written that in the chat, Anita, low dose morphine would have definitely helped the patient, because it is a heart is so weak, congestive cardiac failure, elderly, you can't do any surgeries to correct it. Low dose morphine would have worked wonderfully in this patient.
Yes, ma'am.
She has also suggested diaper. I would suggest bedside commode, because she's tired walking to the toilet. Improve her quality of life by giving her privacy and a bedside commode and a 24-hour caretaker, so that even if she has to go to the loo with the Lasix, it is not a tiresome job. So these
Yes,
small things can make a difference. Make the house more geriatric friendly. See to it that there are railings. Maybe
yes,
use of oxygen. I don't know. Maybe she had low oxygen. That can also improve the cardiac health. So a lot can be done. And believe me, her grief itself would have been made her non-compliant. Also, one of the things we address in palliative care is to knock off unnecessary medications. Imagine at 76 to take 1 page full of medications. That only will fill your stomach. What nutrition are you going to end up eating? So rationalize medications, whether you need to give it every day, whether you need this for the patient. So rationalization, controlling of polypharmacy, improving her exercise capacity by physiotherapy, counseling for her grief, making her house more geriatric friendly, low dose morphine. And the cause of death in sleep, she's very blessed to have died in sleep. Otherwise, she would have ended up on the ventilator, knowing the number of visits she went to
yes.
the hospital. So
Actually, she was
cardiac,
very, very happy. Like it was, this thing happened before one day of my marriage. She slept. She was totally fine. She was used to. She was very, very non-compliant. All the drugs she was prescribed. But during few days, like day before my marriage, she was taking medications regularly. She didn't have any complaint of breathlessness. Nothing was there. She went off to. She was also very excited for the marriage, but she slept at night and did not wake up.
so
Well,
two
I'm
things
like,
here. That means she was better off without the medications, and by taking regular medications, that is no, just making light of it. But second thing, it is probably a cardiac event. She was too excited, and all those emotions also can cause abnormality in the rhythm of the heart. So that is unfortunate of the timing of the death, but the manner of the death, she was indeed blessed, despite
yes,
the number of visits she made to the hospital, etc. But I hope you managed to get married the next day, or was it postponed?
no, ma'am, we got married.
Yeah, good. So that is good, because I think it's important to have the blessings of the elders. But
Yes.
I think she went in a very good way, even though she had a very rough journey to the end. Sunil, you want to add?
Uh, Actually, what you have told, all those are very good points. So I would like to explain it in another way. That this patient actually didn't want to have needles and hospitalization. And if palliative care team were involved in the process, then they would have talked regarding why you don't want to visit hospital, and do you know about the problem that you have, the disease that you have, and then we would be able to come to a conclusion regarding what would be the goal of care and where you should be taken care of, and if there is acute event, how that need to be um, treated, etc. So all those would have been in and actually not only with the patient but also with the family members. That's also important, because otherwise in an acute event the family members will be very much frightened and they will take her to the hospital. So it is important to talk to both patient as well as family regarding the what is happening and what can be done in those events. And another thing would what can be done, or what all can actually expect to occur in her yeah to her. So maybe most probably it can be acute breathlessness or cough, and how can we treat these symptoms at the house itself? So if that breathlessness occurs and unable to manage with the medication that is with the patient, then what can be done? Maybe something like maybe morphine or even benzodiazepines like midazolam. All this will help to manage the episode of breathlessness, so that she need not be shifted to the hospital and can be managed at home as per her wish. So these are a few points which I wanted to add.
Yeah, thank you, Sunil. Because the
Thank you,
whole
sir.
point is you cannot reverse her age, you cannot reverse her cardiac health. So a lot of it is incurable, but the least we could do is keep her comfortable. And that comfort, if she's not happy to going to hospital, we should be able to give her at home.
Yes, ma'am. Thank
That
you.
is the thing.
Thank you so much, ma'am.
Thank you. Any more comments or suggestions?
Ma'am, what are the antifibrinolytic drugs which you give?
We give perfenidone, which is basically in the dose of 1800 to 2400 milligrams a day. So we start at 200 three times a day, then make it 400 three times a day, then 600 three times a day. So that is perfenidone. And the second medication, which is now being made available in India at an affordable price, is nintedanib. Nintedanib is
Sorry?
nintedanib. I will put it
Yes.
here. Perfenidone and nintedanib. This is given in the
Nin,
dose of 150 milligrams. It's a tongue twister, twice a day. Yeah, 150 milligram twice a day is the dose, like Dipti suggested. But if both these medications are very strong on the gut, there is a lot of nausea, diarrhea, loss of appetite, loss of weight. So again, in a patient with advanced progressive fibrosing interstitial lung disease, you have to weigh the benefits and risk. Because the patient is already so advanced. Yes, there is evidence that these antifibrotics delay the fibrosis, but it doesn't reverse the already existing fibrosis. If these high doses of the medications make the patient stop treatment, stop eating, lose weight, that also affects the family member. So you have to weigh the benefit and risk. That's why you have to have a palliative care as well as a pulmonologist in the treatment towards the end of life.
So what palliative care you'll give for this? Suppose he's got a interstitial disease.
So what we
and
do is, for like I said, first we evaluate the history, detail examination, find out how much oxygen the patient is on, especially for 6-minute walk test, how much his oxygen is desaturating, support him with oxygen. We do pulmonary rehab, we do counseling, and we actually sit and talk to the patient of goals of care, with the patient and the family. Because this is progressive fibrosing interstitial lung, we say that it is going to progressively worsen. So we need to plan for emergencies. And like I said earlier, we do give low dose morphine for the breathlessness, and we plan the patient's emergency. So what do you want to do in an emergency? Do you want to go to hospital? Do you want to go to the ward? Are you able to look after the patient at home? Do you want to go to the ICU? From the medical side, intubating this patient and artificial ventilation is actually of no use for this patient because the lungs are so stiff and the lungs are really not taking part in respiration. So it is actually medically futile to intubate this patient. So we actually get a consent of withholding or aggressive life sustaining or life prolonging treatments. Then we communicate to the primary chest physician, we communicate to the casualty, we communicate to the intensive care, so that when the patient lands at any time, the casualty medical officer knows that this patient has expressed interest not to intubate. Then we do all the comfort care, which is 24-hour infusion if necessary, try the morphine, try the midazolam, give the NIV if the patient is comfortable, and let the patient transition in peace. So we look, if we get the patient a good 8 or 9 months before, then there is a lot of time to establish rapport, talk about these difficult situations, talk to the family, talk to the children abroad, get everybody on the same page. You can't say, hello, my name is Dr. Rajam, can we talk about your death? It is not going to happen. So we need time. So we need early integration and we need early referrals. For a long period of time, I still continue to see patients either 2 weeks before death, 2 hours before intubation. It is not at all the time for patients and caregivers to see a new face and to talk about such difficult, important things of their life. And the worst part is, as doctors, you and me know that this illness is chronic, it is progressive, it is incurable. So it is our onus to start that conversation early, saying, do you want to know more about this illness? And do you know how this will progress? Whatever I'm giving you may help, but in the event that it doesn't help, do you have plan B? See, what I also find very surprising is people have plan A and plan B for everything in life except death, which is a surety. Death is
That's
inevitable.
true. That is true.
Death is inevitable, but a bad death is avoidable. People are happy to talk about holiday, plan A, plan B, children's marriage, children's education, everything. But when it comes to death and dying, people don't want to talk about it at all and don't want to discuss it. But it is going to happen to every one of us. And the pandemic has brought that also into such sharp focus, because you don't know who is going to get hit by what and how. So all the more reason we need to have honest conversations, because we are the doctors, not the patients. Patients see they're one patient of ILD, they're one patient of COPD. We have seen 100 more. So we should be able to have that unhurried, honest, sensitive conversation. The way we tell them also about breaking bad news, I'm sure you've had communication classes, but we really need to be the ones to say how this is going to progress, and the fact that we are here for supporting you through this journey. But you have to take the call. If you want any info, for you to take the call, I need to provide you with the information. So I will give it to you in small doses, but you need to see to it that you're open to listen to that, because everything I say will not be something like music to your ears. But we are there to support you. It's not that we say, okay, you're going to die and whatever, this thing is going to get worse, you're going to die and walk away. The idea is to be there and to be there with the patient and the caregivers.
Thank you, ma'am.
Yeah.
Anybody else has any more comments?
It is tea time now, Sunil.
Okay, I like the way that you talked about the death. There is no plan for death, but has many plans for other things. Thank you. So, thank you.
It's true, isn't it, Sunil?
Yeah.
We have so many plans for so many things, but we never talk about death.
Thank you, madam.
Thank
for
you.
That, wonderful
Thank
you
you,
for the
ma'am.
opportunity.
Thank
All
you,
of you
Dr.
take
Vaibhav.
care, and I hope all of you and your family is vaccinated. Bye.